Okay, well, welcome to everyone after lunch, and thank you to the organisers for asking me to take part in this session, and to Javier for co-chairing. These are my disclosure statements. The learning goals of this session are to recognise how an optical sensor pressure wire may advance treatment options in the complex subset of patients. To understand the importance of physiological assessment to guide PCI strategy in two different settings. The first of these will be in a stable coronary heart disease, and Nick Curzon from Southampton will talk about the Ripcord 2 study. And then secondly, in the setting of complex multi-vessel disease, Dr. Gonzalo will talk about the results of Syntax 2, of which Javier has been the co-chief investigator. And then finally, to look at the management and the optimal timing of management of non-culprit lesions in patients with STEMI, and that will focus on the full REVAS trial with Felix Baum. I just want to say a couple of brief words about the COMET wire. The features of this wire are that it has a fibre optic sensor, but also importantly, the design of the wire with a single optical fibre in the centre and a very large nitinol core with a laser-cut spiral stainless steel external casing means that this wire handles extremely well, and I think most people who have used it would consider it to be perhaps the most user-friendly pressure wire. It has a very nice spring coil which gives excellent tactile feel, and both the hydrophobic and hydrophilic coatings on separate parts of the shaft of the wire. That's the fibre optic sensor, and it links into your Polaris system using this cath lab side FFR link system. So on the bench, and of course you can take this kind of data as you see it, but in comparison to the St. Jude and Volcano wires, the torque control with that pressure wire design is extremely good and almost one-to-one, and I think again anyone who's used this wire will be familiar with that level of performance. It has a very, very nice self-rotating connecting system, which means that you can rotate the wire infinitely without twisting the cable connection. Because this is a fibre optic sensor, it's not wireless, but the fixed cable connection works through this freely rotating adapter, which gives you a full range of motion of the wire. Endless fun playing with that. Now, just before we hand over to the full program, I want to briefly reiterate some data on the new Boston diastolic pressure ratio that was presented for the first time this morning in an earlier session. So this is a new resting index of stenosis severity, and of course the development of these new resting indices has been provoked by the interest in IFR following the results of the IFR Sweetheart and Define Flare trials. So you'll know that IFR uses ECG gating to identify a period in diastole in which PDPA is measured at rest. That segment of diastole does not have the same resistance as whole cycle hyperemia, and you can see here that almost half the resistance values when you induce hyperemia. Nevertheless, one has to recognise that there are randomised controlled trial data to support non-inferior outcomes. We've done some work on diastolic pressure ratios using the dicrotic notch to identify various periods of diastole and shown equivalent results to IFR. The Boston algorithm, which is demonstrated here, does not use ECG gating or the dicrotic notch. It simply samples PDPA every time the instantaneous PA is less than the mean PA, and the slope of the PA change over time is negative. And you can see here in these top panels, so a schematic, and then the Boston console in the middle and the Volcano console on the right-hand side, with identical DPR values of 0.9 in each of these examples, and identical IFR values of 0.9. And you can see with a more severe stenosis, we have 0.71 across the board. So numerically, the Boston version of DPR matches completely the volcano IFR. And just to show the point in a little bit more detail, there's the scatter plot of DPR against IFR in just under 900 lesions from the Verify-2 and contrast pooled analysis. And biologically, it will not be possible to get an area under the curve of much higher than 0.997. So without further ado, I'll ask Javier to introduce the next speaker.
Thank you very much, Keith. Very interesting results. So we first will ask my colleague Nieves Gonzalo to join us and to present a case based on the syntax 2 strategy, and with highlight the importance of imaging and physiological assessment. Is that correct? Oh, it's Nick. Nick, sorry about that. It's such a small letter. Sorry about that. So, Nick, it's your turn. Is how FFR guidance can impact clinical decision making? A case from Ripcord 2. Thank you.
Well, first of all, thanks to the organisers and to the chairman and to Boston Scientific for asking me to give this talk. My conflicts include the fact that the Ripcord 2 randomised trial is sponsored from an unrestricted research grant from Boston Scientific. I'm the chief investigator for Ripcord 2, and I'm just going to tell you a little bit about the background before I show the case. It's been clear to me for a very long time that some of our strategies for assessing people with chest pain are relatively flawed, particularly because we focus very much on angiography and an anatomical assessment rather than ischemia, and that's really the basic concept behind Ripcord. Our fundamental problem is that however unpalatable you find it, you can't tell from an angiogram which lesion is ischemic and which isn't. So if we're going to spend our lives barking up an angiogram tree looking for ischemia, then we may be surprised to find that we should be looking somewhere else. And that's the basic concept of Ripcord. The original Ripcord study, which was a small observational study, but from which Ripcord 2 was derived, if you plotted all the coronary lesions, plotting how severe they were from 0 to 30% to more than 70% against the FFR value, so above the red line is not ischemic, you see a fundamental issue, which is there's a mismatch, so that there are some quite tight lesions that are not ischemic, and a lot of moderate lesions, and even some quite mild lesions of 0 to 30% that are. Now that was a small observational study, but exactly the same degree of discrepancy was found in the FAME group, in FAMOUS, which was an ACS study, or in this huge series from Bernard de Bruyne's group. And they tell us two very fundamental things, these observations, whether you like it or not. There's a mismatch between your assessment of the anatomical stenosis and the presence of ischemia in about 30% of lesions. And very importantly, there is potential for this mismatch in nearly all lesions, not just the 50 to 70% ones that most people choose to use a pressure wire in, if they bother to use a pressure wire at all. So this extends from very mild lesions to very tight ones. There's a mismatch, and you can't tell from the angiogram which one is which. So our algorithms that take patients with chest pain and do a diagnostic angiogram and then decide on either optimal medical therapy or revascularization are flawed. And there are a lot of very high quality randomized trials that tell us that in the group that's already been committed to PCI, that FFR is useful or IFR is useful in determining which lesions and which patients should be revascularized. But the Ripcord concept is, why aren't we using this power at the diagnostic stage before we triage patients to any of these? And if you look at all the studies, and they're all observational, that have been done where a pressure wire is used at the diagnostic stage, and this is non-randomized data, you see that even getting a pressure wire out at the diagnostic stage in all these populations changed the management in between a fifth and a half of cases. So this is a very powerful effect that we're just not using in the cath lab. So Ripcord 2 is an 1,100 patient randomized trial, and Keith, it's not just stable patients, it's all patients except STEMI patients, so it includes ACS. Testing a hypothesis that routine FFR-guided assessment of coronary disease will be associated with more effective resource utilization, improved quality of life, and better clinical outcome when compared to just doing an angiogram. And the primary outcomes are economic analysis and quality of life. And the secondary ones, as you would expect, include MACE, bleeding, and all sorts of other things about clinical outcome. So let's look at a case. This is a lady who was in Ripcord 2. She's 62. She's got risk factors. She presented acutely with a troponin-positive episode of chest pain. She had T-wave inversion anteriorly and anterior hypokinesis. And this is her angiogram. So what I see is an angiographically important lesion in the mid-right coronary, an angiographically important lesion in the mid-LAD, and a further lesion in the distal LAD that doesn't look so important, and a circumflex which is non-dominant and not significantly narrowed. So the question really is, in this lady's case, what's the right management based on her angiogram? We could have a show of hands, optimal medical therapy, PCI to the LAD, bypass surgery, PCI to the LAD in the right coronary. That's what most people want. So she was randomized to FFR plus angiography, and in this trial you have to do an FFR in every vessel that's of stentable or graftable diameter, regardless of whether it's got a narrowing or not. So it's a very rigid protocol. The circumflex, you won't be surprised to hear, is negative, and the LAD, which was the next one I pressure wired, was strongly positive down here, below the two lesions. So this one looks very tight, and that one looks moderate to me. So I went ahead to treat this vessel because she got some pain while the pressure wire was down. I put a 275 by 30 drug-eluting stent in that long segment of disease. Now the question is, do we need to treat this lesion or not? Now, because I did this on the COMET wire, and the COMET wire is the default wire for this trial, I was able to just reattach it and find out that I didn't need to treat that lesion at all, which is very handy. And then I went ahead and looked at the right, which I think anatomically looks quite important. And the FFR was robustly negative, so that was the end of the case. I could probably have put two more stents in than I did in this case. Here's another case. This is a 67-year-old man with risk factors. He's got stable angina, which is getting worse. He's referred for an invasive angiogram according to NICE guidelines through one of our rapid access chest pain clinics. So again, he's got a moderate lesion in his mid-right. He's got a long, quite important looking narrowing in an OM and a bit more disease in the PDA origin down here. And then he's got a long segment of LAD disease and some disease in this diagonal. How would we treat this patient if we just had an angiogram? I mean, we could have a show of hands. Who's for optimal medical therapy in this man getting a lot of angina? Who's for CABG, bypass surgery? Who's for PCI? That's encouraging. We're in an intervention meeting. But I think you'll agree it's very difficult to know which of these lesions we should PCI, unless you're just going to do all of them every time. This gentleman was also randomized to FFR. Now, I remind you that in this trial you have to do every vessel of stentable or graftable diameter. So this lesion was 0.85. The OM was 0.89. I can't show on the same picture the PDA, but the PDA was 0.93. This diagonal was 0.81 at this point down here, and the LAD, not surprisingly, was 0.66. So we've changed someone with triple vessel disease into someone with single vessel disease in terms of revas target. And so I went ahead to stent the whole of this segment of disease with a 38mm 3 drug-eluting stent. And then because I did it on the COMET wire, I was able to reconnect it very easily and found to my disappointment that despite it looking very good and optimizing it with a non-compliant balloon, the FFR was still only 0.82. So I decided that it must be this moderate lesion down here that was making the difference, and the pullback indicated that it was a step up. So I put a second stent across that lesion, producing this end angiographic result. And the question is, have we finished or not? And of course I can just reconnect the COMET wire and confirm that we've rendered this vessel robustly non-ischemic. So the Ripcord concept really is challenging people, I think, to this question. Should we measure some kind of coronary physiology? And I don't care what type of coronary physiology it is. I don't care whether it's FFR, IFR, PDR, any other of the many diastolic parameters that are now going to come online. The key is, if you just use an angiogram, you're going to get your lesion assessment wrong in 1 in 3 lesions, however experienced you are, and you're going to get your patient's management wrong in between a fifth and a half of cases. That's not what you want, and it's not what they want. As of last week, the Ripcord trial had randomized 1,052 cases, so we've got just over 40 to go until we finish completion. And I look forward to presenting the results sometime in a year's time. Thank you very much.
Okay, so very, very nice presentation of a very important concept and trial. We'd like to invite the audience to engage and interact with the speakers. And if you'd like to come to the microphones, preferably, because this session is being broadcast live.
Stunned.
I mean, in the meantime, well, we have some comments from the colleagues. I think that's something that is very interesting, is that when you are performing more and more physiology, you learn to be, say, more skeptical about your ability to outline if a stenosis is severe or not. I mean, I was again surprised with this right coronary artery that you show us. And the message is extremely important, not only for the patient, of course, but when you perform regularly and you perform a comprehensive assessment of this complex disease, what happens is that your colleagues become very fond of it because they really simplify a lot their procedures. And in many occasions, they do not have to address a very challenging scenario, perhaps a bifurcation or a situation, because simply there is not an indication to treat that stenosis.
But it does, of course, work the other way around. I mean, there are cases I've done where I've been quite surprised, and I have to confess, as an interventionist, a bit disappointed, where I found a case that I'm sure only needs one stent, and actually 3 vessels are ischemic. And I think one of the very, very important messages to people who don't use intracoronary physiology very often at the moment is, don't forget that it's not just this 50 to 70% range that the pressure wire has the power to affect your judgment. It is right across the spectrum from at least 30% to 90%. And I think this is one of the biggest misconceptions, that people reassure themselves and say, well, I get the pressure wire out for intermediate lesions, but that's not, I don't think, what the evidence base suggests. I think you need to use the pressure wire in a lot of coronary lesions in order to find the ones that give you a surprise.
Just to clarify for the audience, Nick, then, within the trial, are the investigators asked to define their management strategy on the basis of the angiogram only before randomization?
No, because we did that really in the pilot, which was the original Ripcord. In this trial, it's comparing operators having FFR and angio versus the other arm, which is angio-guided alone. So this is a genuine strategy comparison.
So there'll be a collection of patients who've had surgical revascularization.
So in the angio arm, in fact, in the trials that have looked at enough patients, you may be surprised that in some of them, including the original Ripcord, which was a pretty small trial, but the number of bypass operations in the group as a whole didn't go down. It was just completely different patients. And that's really quite scary. So a lot of the people in these studies that have used pressure wire have shown that people committed to bypass surgery turned out not to have 2 or 3 vessel disease. They had single vessel disease, which could be treated with stents, according to physiology. But there were also other cases where the operator on the angiogram had decided to do just a stent to 1 vessel, and then they ended up passing the patient on for bypass surgery on the basis it was triple vessel disease. So it works both ways, and the whole point is you just can't tell. And that lesson is probably long overdue for some operators around the world.
So some of the interesting aspects of what you show us is that you use pressure guide wire to check the result of your PCI. You show us that.
Yeah, that's not part of the trial. That was just my personal preference, because I'm pretty convinced by the data that the FAME group, and we did another meta-analysis earlier in the year that suggests that if you do check your result, you can present some association with long-term outcome. And I think often, I mean, there are various reasons why you put a stent into a lesion and it looks great angiographically, and the FFR is annoyingly still quite low. One of the commonest being that if you IVUS your stent, you'll find that you haven't deployed it properly or it's the wrong size. But sometimes there is other disease that you've underestimated. And so I think it is a really useful way of ensuring the best possible outcome. And after all, if you're going to use the pressure wire on a lesion to decide whether it's ischemic and you're going to justify stenting, there is no need to put another wire down. You can just do the intervention on that wire and then reconnect it and check it at the end. It's very simple to do. But you have to be prepared, if you're going to do that, to not stop, because sometimes you don't get the result you want.
Any more comments from
May
the
I have a
colleagues?
question? Yeah. Over there.
Oh, yeah.
Okay.
I have just
Sorry.
same question. How often do you perform the post-stent FFR? Because I can tell you time to time, or very frequently, is really disappointing to measure post-stent FFR, because your angiography findings looks very good, and FFR increased by 0.04. So it's not rare.
Well, I don't think that's disappointing. If you set off to render the patient's lesion non-ischemic and it's still less than 0.8, it's not disappointing, it's a triumph, because it means that you're going to get the result right. What's disappointing is that you've got to stand there and sort it out before you can go home. But it's not disappointing for the patient, I assure you, that's what they want.
And it's also a very interesting, way of benchmarking your results. I think that we have, as interventional cardiologists, for a long time, we were so proud of our achievements that now when you really have a look in what is the impact on the hemodynamics, you learn that you have to be a bit more humble and understand that
Yeah, and I mean, it's never a bad thing to know you haven't achieved what you set out to. I think it also, if you've got very diffuse disease in a vessel, it often makes me think very, very hard about tackling that by PCI, because it can often, in very diffuse disease vessels, be difficult to get an FFR that's in any way non-ischemic.
Thank you very much, Nick. So I think that we will move to the next presentation. Thank you.
Okay, so it's my pleasure and privilege to introduce Niamh Gonzalo, from one of Javier's colleagues from Madrid, who's going to talk about the Syntax 2 study, which I think we've seen results from at this meeting earlier, and I guess we'll get a more detailed look at the data now. So thanks very much, Niamh.
So thank you very much, first of all, for the invitation to participate in this symposium. These are my conflict of interest. And well, we all know that the recommendations for multivessel disease treatment are largely influenced by the results of the Syntax 1 trial, but there have been major changes in PCI technique since Syntax 1. So the Syntax 2 trial basically tried to address whether the implementation of all these improvements could mean also an improvement in PCI outcomes for the patients with multivessel disease. So the Syntax 2 strategy is basically this holistic approach to PCI, trying to implement all the improvements we have had and try to get the best possible result for the patient. And all these improvements include better risk stratification through the incorporation of not only anatomical, but also not only angiographic, but also clinical characteristics of the patient through the Syntax 2 score. Also, the physiology-based revascularization, we have already seen how important that can be. Also, the use of new generation stents, specifically the Synergy stent was used in the Syntax 2 trial, and IVUS optimization guidance. These together also with the implementation of the new CTO techniques that have increased a lot the success rate in this type of complex cases. So this is the study flow chart of Syntax 2. And similar to Ripcord 2, all the lesions that were intended to treat were evaluated with physiology. Only the lesions that have functional impact were treated using the Synergy stent, and then they were optimized using IVUS. So I'm just going to show you a case trying to demonstrate how can you implement this Syntax 2 strategy in a case example from our clinical practice. This is a case from 2 weeks ago. This is a 72-year-old woman with diabetes that is admitted for progressive angina. Echo was normal, and here you can see the angiogram. You can see that she has this lesion that looks pretty moderate, but in the proximal RCA, and then she has this stenosis in the mid, LAD in bifurcation with a diagonal. You can see there the calculation of the Syntax 1 and Syntax 2 scores. So following the Syntax 2 strategy, the first thing is to evaluate the lesions with physiology. And we started with the RCA evaluation. You will see now again the angiogram we performed during the case. Again, you can see this RCA lesion. We evaluated FFR using the COMET wire, And here you can see how we did this. The case live, you can see this feature that Professor Oldroyd was commenting about, how you have the capacity to rotate it, which is very useful. And this is the FFR in the RCA, which was 0.89, so negative. So now we move to the next lesion, which is the LED. And here you can see again the angiogram of the LED with this lesion in bifurcation with a diagonal. It looks like there is some calcification by angiography. So now we move to physiologic evaluation of this lesion, again using the COMET wire. And here you can see this is live wiring of the LED using the COMET. We have been also commented the properties of the wire. It has very good capacity actually to adapt to these curvatures and this tortuous distal LED. And you can see this is wiring using this roadmap, this tool we have for these cases. So this is the FFR in the LED, which is positive. It was 0.77. We also performed an FFR pullback. So we pulled back the wire to demonstrate the type of stenosis there, and we demonstrated that there was a focal jump in pressure. So demonstrated that the jump in pressure occurred at the level of this lesion in the mid-LED. This is the FFR pullback. So now we're going to do PCI in this vessel. We can disconnect, as you can see, the COMET wire, and we're going to use this wire to do our PCI. First thing is to evaluate properly this lesion with IVUS. So you are seeing now the IVUS pullback. You will see now that the distal part of the lesion is a very tight stenosis with almost a calcific ring, as you can observe there. If we go a bit more proximal, this is more normal part of the vessel, but now we're getting into the proximal part of the lesion where you can see a lot of calcium, almost 180, and also some degree of positive vessel remodeling. So we have evaluated the characteristics of the plaque and the distribution, and now we're gonna look for our references, the stent landing zones. So first we check now the distal reference. You see this is a good landing zone for a stent distally with a diameter of around 2.8. And we move now to the proximal reference. And you can see that diameter there is 3.5. We're using the lumen and not the EM because there's actually a lot of plaque. Actually, there was not a normal, completely normal part of the vessel without plaque in the proximal part. So the findings until now are that we have a functionally non-significant proximal RCA stenosis. We have an ischemia-generating stenosis in an LAD with this focal FFR pullback pattern. We have a calcific, we know that this stenosis in the LAD has a lot of calcium and some positive remodeling, but almost ring of calcium in the distal part. And we also now know with IVUS the LAD dimensions and the stent landing zones. So now we move to treatment. And based on the findings on IVUS and the severe calcification, we decided to prepare the plaque with a cutting balloon. We used the Wolfram, which is the last generation cutting balloon with a much better profile. You can see here that actually we were not able to advance the balloon while we had the wire in the diagonal to protect the diagonal. However, we retrieved this wire in the diagonal, and after that it was possible to advance the cutting balloon and perform a pre-dilatation to prepare this very calcific lesion in the mid-LAD. This is the rewiring of the diagonal after the pre-dilatation with the cutting balloon. And actually we used a second cutting balloon of 2 millimeters, the other one was 2.5, to predilate this distal part of the lesion where you have seen there was this ring of calcium. So after that, now we move to stent implantation, and we chose a 275-32 stent based on IVUS. You remember that the distal landing zone had a 2.8 millimeter diameter. So we chose this stent, and immediately we post-dilated the proximal part with a 3.5, also following the IVUS. And this is the IVUS post, where you can see that there is good stent expansion and apposition. There are no dissections. You will see how there is a tapering of the stent according to the vessel size. So the proximal part that has been dilated with 3.5 looks good. And overall, a good result of the stent in IVUS. This is just the proximal part of the stent, and we're reaching now the proximal edge. There were also no dissections, even when we had plaque there. This is the angiographic result. We also checked the FFR in the LAD to reconnect the COMET and check the FFR. That was 0.92. And we also wanted to check this diagonal. You can see that there is some pinching in angiography. We wanted to check that. So what we did was put in the COMET that we had in the LAD in the diagonal branch. And we performed this FFR in the diagonal branch that was 0.85. So normal FFR in the diagonal branch, no need for further action at this level. And this is the final result. So with a good angiographic and functional result, we finish this procedure. So this is an example of how to implement the syntax strategy in a case. And this is actually the result of the primary endpoint of the syntax trial. This has been just presented in this meeting like 1 hour ago by Professor Sorois. This is the 2 years results of the syntax. And basically, they demonstrate that in patients with three-vessel disease, the use of the syntax 2 strategy is associated with improved clinical outcomes at 2 years, as compared to matched patients treated percutaneously in the original syntax 1 trial. So the implementation of all these improvements in PCI technique seems to have impact on clinical outcomes. So if we have a look now to the components of the syntax strategy, of course, the first one is clinical and anatomical evaluation of the patient, bare clinical assessment of the patient. This is always the basic of all we do. But the other very relevant point is physiology-based revascularization. I think it has been emphasized already by Dr. Courson how important it is to treat only lesions that are significant and how lost we are actually with angiography. Actually, in the syntax 2 trial, as you can see, almost 1/3 of the lesions, 31% of the lesions, could be deferred because they were not functionally significant. And you can also observe how the number of lesions that were treated per patient in the syntax 2 is much lower than the number of lesions treated in the syntax 1. And this is very interesting, the third part. I mean, how many of these three-vessel cases by angiogram are real three-vessel patients? Only 37%. So this really makes a big difference, I mean, using physiology. The other important component, of course, is the use of better stents that were used in the syntax 1 trial. And in this regard, the synergy, as you all know, is a thin strut stent with everolimus eluting and a bioabsorbable polymer. And the third component is optimization. And when we talk about IVUS optimization, we don't mean only that you implant a stent and you do an IVUS post and then it's fine. IVUS optimization is what I just showed. I mean, so you do your IVUS you prepare the lesion based on these findings, and you optimize your implantation based on that. So you can see that in the syntax 1, only 5% of the patients had IVUS, while in the syntax 2, it was almost 84% of the patients. So as a summary, I would say that the syntax 2 strategy incorporates all the technical and procedural developments in PCI with the objective of improving outcomes in patients with multivessel disease. It has been shown that physiological evaluation in these patients can identify lesions that do not have functional input, reducing the number of lesions that need to be treated, and treating only lesions with functional input using a last generation DES, in this case the Synergy, implanted with IVUS optimization, has demonstrated improved outcomes in patients with multivessel disease. And thank you for your attention.
Okay, very nice. So any questions from the audience? If I could just encourage you again to go to the microphones if you have any questions so that we can record them and broadcast them. So Niamh, you're too young to remember this, but the syntax trial used the Taxis Express 2 stent. And in fact, even in the UK, we had to go backwards to use it because we had already stopped using it and we're using Taxis Liberty. But we had to go back to using Taxis Express 2 so that all of the centres in the trial used the same stent. Now, Synergy is clearly a dramatically improved device compared to Taxis Express 2. Do you have any data on, for instance, I didn't see the earlier presentation, target vessel failure rates? Because it's difficult, I think, to disentangle the three components that you described and to which extent they are all contributing. It's a package of improvements in how PCI is performed. How much of it do you think can be ascribed to the difference between Synergy and Taxis Express 2?
Yeah, I mean, it's almost impossible to know, I mean, how much all these components are contributing to improvement, but definitely the evolution of stent technology and the synergy stent is a big part of the big differences we have in the two results. This is the 1 years.
Yeah.
I think
Do you have
this
the
is repeat
2 year?
revascularization.
Do you have the 2 year?
I think so, yeah. Let me just, yeah, this is the 2 years. This is the repeat revascularization after 2 years.
Okay.
So, yeah, the main differences actually were, of course, in repeat revascularization, as you can imagine, but also in MI, and probably related with the fact that in syntax 1, small vessels and lesions that probably were not functionally significant were treated. And of course, when we're treating this kind of small vessels, we can always have more of these problems. But also, I think it's very interesting also that death is becoming almost also significant in the 2 years. Maybe Javier can comment about these results.
Yes, I mean, if you go to the previous slide, which is very interesting, basically, this one, thank you. What you can see here is that the huge difference takes place periprocedurally over the next, the first few days. And this, of course, has to do with the fact that the new generation stents, a stent like the synergy stent, that has a very thin strut, that occludes very small vessels, that has less thrombogenicity, that has less associated acute thrombosis. All these decreases a lot the number of events pre-procedurally.
Yeah.
But as you rightly mentioned, this is testing a hypothesis. So in this also takes into account that you treat less stenosis and that you expose the patient to less risk. So when you see this difference, you have to take into account that both the developments, the technology that we're using now with the synergy stent, but also the much more cautious attitude of treating only what it is required is contributing to decreased myocardial infarction.
Definitely.
And of course, it will also contribute, because that's another element of the syntax strategy, is optimal medical treatment. Now, once said that, there was one work presented now at EuroPCR looking to the difference between the different antiplatelet agents in syntax 2. We were not able to identify a particular advantage of any of the 3 antiplatelet agents that were used. I don't know if it's because the study has not granularity enough to identify that or not.
Yeah.
But in any case, all these things, of course, help. Yeah.
Yeah, I mean, the figure of comparing the proportion of patients. I mean, this is not a randomized trial, of course. It's a propensity score matched comparison against the syntax 1 data. Nevertheless, it's a huge difference in the proportion of patients who underwent 3-vessel PCI in syntax 1 compared to syntax 2. And in fact, in the FAME trial, there was actually 14% of patients who got no stents at all because they didn't have any significant lesions. Nevertheless, if we could just show the repeat revascularization slide. So I wonder how many of us would say to our patients, you've got a 1 in 10 chance of needing a repeat revascularization at 2 years if I treat you with the best possible stents, physiological guidance, and IVUS optimization. Do we think that is as good as it's going to be? Because I've heard people say, this is it. This is as good as we're going to get with PCI.
I'll give you some additional data in my final take-home messages about what type of events do we have here, what is the distribution. But overall, it's a very small number of patients that had a problem. And unfortunately, it was not predominantly stent thrombosis, which I think that is nowadays the Achilles heel of stenting. I mean, it's the really feared problem that we have. So again, we go to some analogy that we used at the time of syntax, of the original syntax study, is that you tell the patient, well, you have some problem in your teeth. What do you prefer? Do you prefer to take them out and to get a full prosthesis, prosthesis, or do you prefer, to have now a repair and perhaps at the expense of having to come in the future, etc., etc. And I think that this is, you see, reflecting in a way something that is very important. The endpoints are perceived in a completely different way by the patients and by the scientists or the clinical scientists. We know that for a 70-year-old gentleman, the idea of having a disabling stroke is much worse than having a myocardial infarction, and even perhaps more feared than even death. And and we tend to score higher, for example, the fact of having a myocardial infarction than having a disabling stroke. So all these things have to be taken into account. I think that what is, following what you say, what it is evident is that we have made huge progress in treating our patients with triple vessel disease, and that this takes into account, this is due to all the technical developments that have been performed over the years, implementing what we learned in experimental and clinical trials.
So, you're a very passive audience. I might have to come out and speak to someone. Felix, what do you think of the overall message from Syntax 2? Are you now using PCI as your default strategy for patients with three-vessel disease who are technically suitable for PCI?
Well, we discuss all these patients in the heart team, and if they're available for PCI, we might very well do PCI on three-vessel disease if they're amenable for PCI. That has also to do with resources and the waiting time for coronary bypass surgery, which is sometimes long. And so if both methods are deemed equal, sometimes we can choose PCI for these type of patients if we believe we can get a good result.
Okay. Well, if you'd like to take the podium now, and I'd like to thank Niamh for her great presentation. So I'm now going to ask Felix to talk about a very hot topic, which is the role of functional revascularization or physiological guided revascularization in patients with acute coronary syndromes. As Nick reminded me, there are ACS patients in Ripcord 2, but not STEMIs. But Felix is going to take us into the world of ST elevation myocardial infarction.
Well, I want to thank the organizers for giving me the opportunity to take part in this symposium. And these are my conflicts of interest. So the question is really this: for patients with multivessel disease, what should we do with non-culprit lesions in STEMI and very high-risk non-STEMI? Should we treat them or not treat them? Should we do FFR or not? To give you some background, there have been 2 trials addressing this point. The Promulti trial was published a few years ago, where Thomas Engström and colleagues found that a staged FFR-guided complete revasc following STEMI sometime during the index hospitalization, in the meantime around 2 days after primary PCI, they found that the combined primary endpoint was in favor of doing a complete FFR-guided revascularization. However, you can see that the entire difference lay in revascularization. So you can avoid new revascularizations by doing FFR-guided PCI of non-culprit lesions, but no difference at all in non-fatal MI or all-cause death. So only effect on revascularization. So you can say that it was safe to send patients home. The majority never came back, and they never experienced more death or MI. And then came Compare Acute, where they tested the strategy of doing acute FFR-guided complete revascularization following STEMI. They had a combined endpoint of all-cause mortality, myocardial infarction, revascularization, and cerebrovascular events at 12 months. And they saw that it was in favor also here of complete revascularization as opposed to doing infarct artery-only treatment. This was a 2-to-1 randomization, 885 patients. So they only saw effect on revascularizations, and 83% of the patients were done FFR-guided PCI during the primary PCI. So acutely or staged, it was associated with a reduced need for coming back for repeat revascularization. But these trials were too small, not powered for hard endpoints like death and MI. So we've discussed together that we need to do larger trials to see if we can affect hard endpoints also in this patient group. So the current European guidelines is that routine revascularization of non-infarct-related lesions should be considered in STEMI patients with multivessel disease before hospital discharge, class 2A, level A. However, no data exists on hard clinical endpoints like death and MI, and we're not sure if FFR should be performed in the STEMI setting regarding these hard endpoints. So what should we do with non-culprit lesions in STEMI in very high risk on STEMI? This was a 65-year-old female with anterior STEMI. The LED was open on the first shot, but was then treated with a stent. And then we saw a lesion in the circumflex and also in the right coronary artery. So what would you do for these type of lesions? Clinical evaluation, non-invasive stress test, should we do PCI, FFR, and when should we do it? There are many questions hanging out there, I think. So we included her in the full REVAS trial. FFR guidance for complete non-culprit revascularization, a registry-based randomized clinical trial. It's an academic investigator-initiated study with the Swedish Medical Research Council and the Swedish Heart-Lung Foundation, and also some matched funding from Boston Scientific and Abbott. So the study flow chart is that 4,052 patients will be randomized to either FFR-guided PCI or non-culprit lesions sometime during the index hospitalization as you see fit as an operator, or initial conservative management of non-culprit lesions. And we will follow up endpoints at 3 different times and also through registries. And the primary endpoint is all-cause mortality and myocardial infarction. And the recruitment is, as 2 days ago, 620 patients randomized, and 5 countries are currently enrolling. And this is a collaborative effort, and we're grateful for all the collaborators in this trial, and we hope to activate a few more countries soon. Norway, Poland, Iceland, Germany, UK are coming up soon to be activated as well. So she was included in full REVASC. She was randomized to FFR with COMET, and she came back 2 days later. FFR in the circumflex was negative, and also FFR above 0.80 in the right coronary artery. As shown before, we can use the COMET wire quite easily in multivessel disease because it's easy to shape, and also you could do PCI over the COMET wire, and that's good if you want to measure FFR afterwards. It's quite quick that you don't need to change wires. This is another patient, an ACS patient with multivessel disease, a 68-year-old woman with unstable angina. She had 3 previous stents in RCA, but they looked fine. And then you see in the spider view a lesion here in the circumflex, and also in the intermediate branch and in the LAD. So here is also the LAD lesion. And then we did FFR, the intermediate branch, and was 0.91. We did FFR in the LAD, was 0.75, and you can see you do first the intracoronary injection, and then I did a pullback to the ostium to see that there's no drift. And then you can easily go down in the vessel again to do PCI. Placing synergy stent there, and then after stent in LAD, the FFR was at least above 0.90. And just referring to another session this morning with Dr. Diletti showed the 1-year result of the FFR search trial. He saw that they had actually more myocardial infarctions after 1 year if you leave the patient with with a suboptimal FFR result after stenting. So I think this is important to measure FFR also after PCI. So then we passed down the COMET wire in the second branch of the first marginal, and the FFR there was 0.54, so clearly significant, and dilated that second branch of first marginal, and then the first branch, and then placing synergy stent there, and final result in circumflex, and then the FFR value was improved from 0.54. So the take-home messages are that FFR is possible in multivessel disease in SES, and FFR with IC adenosine at these doses is possible in most cases. It's very quick. You get a plateau phase of just 12 seconds and very rarely gives any symptoms. And to do PCI over the pressure guide wire is feasible and quick. It's easy and quick to check the stent result with FFR also after placing the stent with IC adenosine, and aim for FFR above 0.80 and preferably above 0.90, I would say. So multivessel disease is common in STEMI, and recent EC guidelines say that we can consider revasc of the non-culprit lesions. However, no data exist on physiologically guided early complete revasc in STEMI or high-risk non-STEMI regarding hard endpoints like death and MI. So FFR in non-culprit lesions during index hospitalization is feasible and will be evaluated for hard endpoints in the full revasc study. I think if we do studies like this together between registries and countries, we can establish on data that will affect international guidelines, how to treat these patients in the best way. Thank you.
Thank you very much, Felix. Very, very interesting. And I think it's something, the images you show us of the COMET wire navigating are fantastic. And I think that, as you mentioned, and it was highlighted before by Keith at the very beginning, the design of this pressure guide wire is one suited for complex anatomy. It's certainly a guide wire that you will use in complex coronary artery disease, etc. Now, Keith, you introduced DPR today as a potential resting index in these patients. You were mentioning adenosine. I think that we know that it's very safe. But do you think that in this particular subset of patients, there will be some room for studying the role of DPR, for example, in these patients? I know that you are focused now, of course, in the mainstream FFR, but I'm just asking you your opinion for the future.
Yes. I think that FFR is still the gold standard, has been evaluated in most cases, and you're not uncertain when you've used FFR. And in many situations, when you use IC adenosine, you have no symptoms at all, and if you give the correct doses. So the only thing I would be a little bit careful about is if the patient is really unstable, if they're in cardiogenic shock or just been stabilized from a cardiogenic shock, then I think we should be very careful to do further investigations of non-culprit lesions. They saw that in the culprit shock trial, which is 706 patients with AMI and multivessel disease. So this is a different patient group. These were cardiogenic shock patients where 50% were resuscitated, and doing multivessel PCI at the time of primary PCI was dangerous, so it's increased mortality. So I think in those type of situations, it's better to wait to do the physiological measurements of the non-culprit lesions.
So, Felix, this is an audience of interventional cardiologists, and normally Sweden recruits fast and efficiently into clinical trials. But this one is recruiting a little bit slowly, I think. I just wonder whether you're seeing any change in practice. You know, is there any resistance now out in the community to potentially randomizing patients with STEMI and multivessel coronary disease to quite a conservative control arm? And is that one of the reasons that you're having some difficulty getting people to put patients into the trial?
Yes, I think that could be it. As soon as you start a trial investigating one type of treatment, people think that that's the treatment that we're already using, so they don't want to go back to using the old way. I think that could be part of it, and also that some large centers are more IFR centers, that they're a little bit reluctant to go back to FFR. That could also be one explanation. But I think also that this is a little bit more complex than randomizing to a pill or not a pill. So you need to sometimes take the patient back to a new procedure and so, and to fit that into the clinical schedule, you need to be very focused about the study. I think it is a quite easy and pragmatic study for investigators. You randomize to yes or no, and then you can do the FFR measurement at any time you like during the index hospitalization. So I think that with large centers now coming aboard in Poland and Serbia and the UK and Germany, I think that we will increase speed in recruitment.
Okay, so I think we're on schedule. So I'm going to ask...
excuse me.
Oh, sorry.
Yes.
Question.
I'm
good.
very far.
Sorry.
I have two comments. If I'm too long or too late, just interrupt me, please.
No, go.
Lucian Zarma from Romania. FFR gives, first question would be, gives results which are derived from lesion characteristics balanced to muscle mass involved. So in STEMI, we know that these results are not always very reliable. So this can lead to the situation in which you may leave some tight lesions at risk in place, judging that FFR gives you correct results, which is not all the time true. And the second comment would be that completeness of revascularization based on any method, visual, FFR, or anything else, must maybe be recommended taking into account the characteristics of the center, because not all the operators and not all the centers have the same capability to deal with an accident following an intervention of non-culprit vessel in STEMI or 2 days after STEMI, which is a disaster usually. And if the operator is not very trained or the center cannot deal with that, we cannot impose by regulations, do this or that. It has to deal with the characteristics, basic characteristics of the center. Thank you.
Okay, important points. I don't know, Felix, if you want to respond.
Yeah, well, the first question really is addressed by this slide, that there was a publication a few years ago where they took back STEMI patients 1 month later to remeasure the non-culprit lesion, and it was very good between the measurement that was done during the primary PCI and the 1 month later PCI. So 98% was the same, only 2% crossed the FFR gray zone. So you can trust the FFR measurement done acutely, I would say, if you are not measuring in the culprit lesion.
Yeah.
The second one probably will be highlighting something that is very important, that it is true that only with evidence you cannot treat patients. You need experience as well. So at the end of the day, the true evidence-based medicine is the intercept between having evidence, having experience, and also attending the patient characteristics and singularity. I think that is the most important thing, but you're completely right. I think there are things recommended in the clinical practice guidelines that unfortunately not many centers can afford. But science is good in the aspect that demonstrates that you can deliver that degree of care.
So wise and important words from a very wise guy. And I'm going to ask Javier to wrap up this session now. Thanks very much, Felix. So Javier is going to give us the evaluation of this session and the key learning points for you to take home with you.
Well, thank you very much, Keith. So I think it's been a fantastic session. I just wanted to start with an image, so I can speak freely with an image that speaks about what the colleagues have been showing during the case. This is the real life. This is the type of cases that we are doing nowadays, where we're using physiology not only to set the indication for PCI, but also to make very important decisions regarding treatment. And as Felix has shown in the last presentation, expanding this to very challenging scenarios like a primary PCI, etc. I think that we have repeated this concept of the syntax 2 strategy because we talked about the stents, we talked about physiology, we talk about imaging, we talk about patient characteristics. In a way, this type of holistic approach that the syntax 2 strategy explores is trying to put together best PCI practices, scattered knowledge that it is there, that we can pull together, we should pull together as much as possible, and that it demonstrated that actually at 2 years, like now what you are seeing is the primary endpoint of the syntax 2 study. It's a combination of the ones that Nieves showed. At 2 years, still shows a clear benefit in terms of patient outcomes, important patient outcomes. And even if you look to the comparison with the surgical group, and again, taking into account what it has been highlighted, that this is a matched cohort of patients from the syntax study, from the surgical arm, but what it looks is like at 2 years, even when they looked like there was a possibility of crossing at 1 year, now you can see that still you have non-inferiority of PCI compared with CABG if you follow the syntax 2 strategy and if you take as valid the results of surgery in the syntax trial. Now, very few patients at 2 years had events. Only 20 patients. Only 20 lesions, as a matter of fact, in 14 patients. And as the dominant cause for this was in-stent restenosis, 17. Now, one of the more important main concerns that the colleagues have when they are performing physiology is to leave alone this very tight stenosis where you find that FFR is non-significant, and particularly in patients with triple vessel disease. Well, these results are very reassuring. As you can see, only 3 patients, only 3 lesions that were left untreated on the grounds of physiology had a progression in 2 years' time. So it is very reassuring on the concept that deferral based on physiology in these cases, in these patients, is safe. Now, we also learn, and this is different communication by Nicola Ryan, that if you combine the syntax score with physiology to generate what it is called the functional syntax score, you also have a much higher predictive prediction of the risk of the patients. In the syntax 2 trial, as you know, the syntax score demonstrated that there had no predictive value because these patients were already selected on the grounds of the syntax 2 score, which included also clinical variables. But what you can see here is that actually if you combine the syntax score and the information obtained from FFR, you have a fantastic predictive, fantastic way of scoring high-risk patients, those that have a functional syntax score more than 22. So the final remarks then is that on the grounds of available evidence, physiological guidance should be envisaged as an indispensable element of coronary revascularization, particularly in complex PCI. I think that is where you see a marked reduction of stenosis that require treatment, and you see major reclassification in treatment from the 3 modalities of PCI, CABG, and medical treatment. And what we have learned also in EuroPCR 2019 is that at 2 years, the syntax 2 strategy has demonstrated that integrating or combining in a holistic strategy all this scattered knowledge results in better patient outcomes. So thank you very much for your attention. And thank you very much again now to the sponsors for this session, for your attendance. Thank you.